So this is just I don't think we will be able to finish it, but I'll just give little bit of insights into the abdominal wall defect, a practical approach, pragmatic approach, and later on we will continue with this. So Ishwar has already alluded about the embryology. So basically what happens, initially there will be a flat disc, but then there will be foldings of this disc from all the directions, from the cephalic end, from the caudal end, and from the lateral end. And all this end, when there is folding from all the sides, it has to come to a center, and that epicenter is the umbilicus. So when the folding starts from all the four directions, it converges at the umbilicus. And if there is defect anywhere in folding, if it's cephalic folding, caudal folding, or lateral folding, it will give rise to various kinds of abdominal wall defects, which Ishwar has already told. So, but apart from that, one more thing we have to remember is at around 6th to 7th week, abdominal cavity of the fetus is not that capacious. It is small volume. So it is not able to accommodate the entire gut within itself. So what it does, it takes the gut rotates 90 degree and goes into the extra embryonic coelom through the umbilical cord. So there is herniation into the umbilical cord. Okay, it goes into the extra embryonic coelom, and then as it grows, it comes to like 12 weeks, 11 weeks, 12 weeks, or 13 weeks. It again, by that time abdomen becomes more capacious, and this bowel which has herniated into the umbilical cord takes 270-degree counterclockwise rotation and again comes back inside the abdomen. Okay, I think it comes back into the abdomen. Now when we talk about omphalocele, there are two mechanisms. One mechanism is where you see a small omphalocele. This might be one of the mechanism that the bowel, the gut, which was supposed to take 270-degree rotation anti-clockwise and return back into the abdomen, has not happened, and that's why there will be omphalocele. And also we have to be very careful that if there is we are scanning a little bit early, 11 weeks or so, and we see something echogenic protruding, so this is most likely a physiological omphalocele. So we have to wait for 1 or 2 weeks more to see before we pronounce as a pathological omphalocele. And one more thing, that this is for about the small omphalocele. The larger omphalocele which we saw that day, they may be because of the faulty closure of the lateral walls. I told you cranial, caudal, and lateral. If there is insufficient closure of them, then there will be a long segment defect. Okay, so these are the probable etiologies. Now how important it is, that we will see subsequently. So which anomalies should be targeted? Now if you look at all these abnormalities, there are three broad categories of abnormalities. One is nearly always detectable. Nothing is 100% in medical science. That's why it's 90 to 100%. And the other group is in green is potentially detectable abnormalities, and one in blue is virtually not detectable abnormalities. Now if you look at these two, red bar and green bar, you will see there is altogether 5 abnormalities which we are supposed to pick up. Amongst them, in nearly always detectable is your omphalocele, gastroschisis, body stalk abnormalities. And then potentially detectable is your spina bifida. Why spina bifida potentially detectable? Because sometimes it may be closed spina bifida, which is difficult, and bladder exostrophy. Again, sometimes bladder exostrophy may be tricky. So these all abnormalities which we are supposed to pick up, how do we do that? The simple rule is we go step by step. How do we evaluate abdominal wall? Once we start scanning the fetus, we should understand what are the key steps which will enable or which will give us a red flag that there may be anterior abdominal wall defects. Sometimes anterior abdominal wall defects will be very glaring. You put the probe and everything is floating, but sometimes it may be very small also. So we have to go step by step. So in abdominal wall, what are the things we are looking for? Integrity, correct cord insertion, look at the bladder, and look at the 3 vessels. So we are looking at all of this. So this is the region of the cord insertion. So always we have to document the region of the cord insertion in axial plane and also in the sagittal plane. So this is how the cord insertion goes, and then you have your umbilical artery, and then your umbilical vein continues at ductus venosus, and then it inserts. So these are, this you can see the free floating thing, it's not covered by the membrane, whereas this, if you see, this is a normal cord insertion, right? And this, if you see, there is a ball like thing. So this is normal cord insertion, so you are supposed to see this kind of. So always, right from the first trimester, you are supposed to document cord insertion in this manner, because if you are doing that, it's less likely that you will miss on anti-abdominal wall defect. And then if anything protruding like this, like a broccoli, is most likely gastroschisis, which is not covered by the membrane and has a normal cord insertion, and this like a ball which is encapsulated or surrounded by a membrane, and then insertion of the cord will be in the apex of the defect, this is most likely omphalocele. So these are the two major players where we have to be careful. This is already Ishwar has discussed with you. Okay, in this, if you just few things I want all of you to see. Gastroschisis, many times the problem is how to differentiate this. So gastroschisis, you will have normal cord insertion. Okay, forget about right or left paramedian, but you will have normal cord insertion, and just by the side of the cord insertion there will be a defect which will be like bowel contents, and it will not be covered by any membrane, and it will be like free floating. Okay, so these are all gastroschisis. And omphalocele, you will have a membrane around it, it will be well circumscribed, and cord insertion will be on that membrane. Okay, rest of the things we will see when we discuss them. So when we discuss about the spectrum of abdominal wall defect, AWD is abdominal wall defect, so there may be all of this. So I don't want you to get confused with this, so that's why we will look at the very basic things and try to extrapolate. Now this is again a busy slide, I will not go into this, I will take you to this slide later on when you understand better. Now this diagram, you see this, everything is floating and not covered by the membrane. Okay, so this is gastroschisis, and you will see like this, the bowel and everything is herniated here. And here if you see, this is well circumscribed and cord is inserted on the apex of this, and this is the cord insertion, and this is the membrane. This is the membrane covering it, so this is omphalocele. Now these are the characteristics of the omphalocele. You will have a covering membrane, location of the defect will be center, median, umbilical cord insertion will be at the apex of the defect. Then herniated abdominal organs can be anything. If it is small, it will be only bowel, but then it may be liver if it is large. Associated anomalies are very common with omphalocele. Chromosomal defect, there is high association, and prognostic factor depends on the associated abnormalities and on the chromosomal abnormalities. So when we are looking at the omphalocele, we have to be careful about two things. One, omphalocele is associated with other structural abnormalities. Okay, so we have to look into in detail at the entire anatomy of the fetus. And second is the genetics, because they have very high association with the chromosomal as well as the monogenic disorders, the syndromes. This is just the incidence and theory. This is just a picture to show you how omphalocele appears. This is again, this is physiological omphalocele. If your CRL is less than 45 millimeter, a diameter less than 7 millimeter, and there will only be bowel content. So these are all physiological omphalocele. Now this is just a 3D rendering at 13 weeks 3 days of this omphalocele. So this 3D rendering or these things does not give you any additional advantage. It's just to demonstrate the same defect which you have seen in the 2D. Now I'll just quickly go through this gastroschisis. In gastroschisis, as compared to the omphalocele, there will not be any covering membrane. Location of the defect is always to the right of the umbilicus. Umbilical cord insertion will always be normal. Herniated abdominal organs, mostly there are bowel, and this sign is called a broccoli sign. Associated abnormalities are uncommon. Chromosomal defects almost nil, and prognostic factors are dependent on the condition of the bowel. So here it's less likely you will find associated structural abnormality, and you don't need to do any genetic analysis once there is gastroschisis, because there is no association with genetic problems. So when you prognosticate these fetuses, it is important to tell the parents that there is very high likelihood of injury to the bowel, because now it is exposed in the amniotic fluid, which is not the right environment for the bowel to be. So they may have functional as well as anatomical problem in the bowel, and because of which it may need multiple surgeries postnatally. So prognostications will depend only on the bowel, because when there is contact with the amniotic fluid, there will be chemical damage. Okay, and also herniated sac, there will be constriction at the neck, and once there is constriction at the neck, because if there is some hole and everything protrudes, there will be compression at the level of the neck. It will be bottleneck. So there is mechanical pressure also, mechanical damage as well as chemical damage, and these all causes damage to the intestinal loops, and it's a major factor for neonatal morbidity or mortality, and also long term it may lead to short intestinal syndrome. So this is how the gastroschisis appears postnatally. All the bowel loops you can see here. Okay, and the complications are intestinal atresia, obstruction, stenosis, perforations, all this.
So the right side होगा ना?
हाँ?
Side होगा ना? तो abdominal wall defect दो तो lateral fold आते हैं.
हाँ.
Why always in the right side?
You will tell me that. There is one artery. There is one artery there, because of which there is a defect. Which is that artery, you tell me? It's a right question, but you tell me that. Okay. Now I will just quickly compare them. Okay, quickly compare them. Chromosomal abnormalities in omphalocele, I told you it's very high. Okay. Apart from chromosomal abnormalities, there is association with the syndromes like Charge syndrome, OEIS, Cantarell, Beckwith-Wiedemann syndrome. Associated abnormalities are very high in omphalocele as compared to gastroschisis. Congenital heart disease is also very high in omphalocele, almost as much as 50%. But however, stillbirth is more common in gastroschisis, right? Because of the bowel injuries. Small for gestational age is again more common with gastroschisis. Intestinal complications, as I have explained you, is more common with gastroschisis. Okay. So just we will finish off with this. Later on I will show you some more differential diagnosis. So when you are talking about omphalocele, we have seen what are the herniated contents, herniation site, umbilical cord status, amniotic membrane, then the coelomic space, what are the factors responsible for fetal mobility, morbidity, and then the status of the spine. So in this case, if we see, there were one was we got large anterior abdominal wall defect, which was a little bit inferior. I mean, it was not like, if you look at the site of the herniation, it was just inferior to the cord insertion. Okay, cord was abdominally inserted, but it was little bit antero-inferior. And the other factors which was very unusual was genu recurvatum, and then there was scalp lesions. There was scalp lesion, and what was one more thing? Genu recurvatum was there, scalp lesion was there, and herniation. So these three only were there. So we were thinking what this could be, and also we did not see the bladder. So we got so we were suspecting why this, and spine, kyphoscoliosis of the spine. So we thought might be OEIS complex, because in if you look at the OEIS complex, there might be this omphalocele, obviously, with spinal abnormalities and non-visualization of the bladder. So in this, O stands for omphalocele, E stands for exostrophy of bladder or cloacal exostrophy, whatever. Then I stands for imperforate anus, which is difficult to pick up at 20 weeks. And then S stands for the spinal abnormalities. So as per the criteria, if you meet at least two of this, it should go in the OEIS diagnosis. but we cannot confirm it definitely, but structurally at least phenotype was like OEIS complex. So I think in next presentation again we will have again a discussion on this to finish off this, because I am having some more differentials and some syndromes like this Beckwith-Whitman syndromes and other syndromes. So I just want to give a brief outline of those syndromes, and then we will stop here, and then we will start your. Okay, thank you.